going to give an overview of shock and some of the things that we do in the ICU. And some of it's going to be review, which is also important. And I'm going to talk about some new therapies for septic shock. I'm not going to get too much into cardiogenic shock because Dr. Patel is going to follow me from the Heart Center and give some really good examples. And then we'll talk briefly about PE. Briefly, classification. As you guys know, 4 main classifications: distributive, hypovolemic, cardiogenic, and obstructive. Sepsis is the most common of all of this, and it's what we see in the ICU quite frequently. So we're going to talk about some things with sepsis as well as pulmonary vascular. And one brief slide on neurogenic shock. The approach to treatment, in general, without getting into specifics, from a paramedic end, you're going to want to replace their volume, whether they're bleeding or they're hypovolemic or they're in septic shock. And, I can tell you that there's been no real difference between crystalloid and colloid. We use normal saline or lactated ringers. There is literature that we want to avoid the starch volume expanders because they cause renal failure more often. And then, of course, we want to be mindful of electrolyte abnormalities once they get upstairs to the ICU, namely potassium and sodium. Just heard a great talk on ultrasound. Identifying the underlying cause is not always possible, especially in the field. But assessment for bleeding, the fast exam in the emergency room, or the echo. Administering therapy, as Dr. Liu mentioned, this is politically controversial. I think there's great opportunity to give things like TXA, even first dose antibiotics, individualized fluid, in the ambulance. But there's a lot of, I'm learning there's a lot of politics that go along with that. Ultrasounds in the ambulance, all very good ideas. She showed you one. The one in the lower right is the GE model. I won't say that this is replacing the stethoscope in the ICU, but it's coming close. Emergency room physicians, same thing, I think. Ultrasound technology is groundbreaking. These are about $3,000. It's all in the probe. The probe that she had, this butterfly probe, is probably the best one. It's a little bit of a back order. This GE probe, lower right, is also very good, but it's a little bit of a flip case. It's a little bit cumbersome. The one that hooks up to your phone is the best. The probes are usually hard to get a very good quality, though. They tend to be a little bit more expensive. I'm not going to get into the fast exam too much, but there's 6 sites that you can look at to really look at a lot of pathology. If you get a good long parasternal view, you can see some pericardial fluid toward the top of your screen. Subxiphoid or long axis view, you can see the heart contracting there, and if this patient is presenting with hypotension and you see a lot of fluid there, that's going to be priority. This is a situation where you have the right upper quadrant fast exam, and you see the kidney. I can't point to this really. I can a little bit. So you see the liver. You see some black stuff to the right of the liver. That's fluid, and that shouldn't be there. So that's diagnostically very helpful. And jumping to neurogenic shock, worth one slide. A lot of the evidence is from Iraq and Afghanistan. We're a level 1 trauma. We are a level 2 trauma. Level 1 trauma is going to see a lot more than of this, and it's usually traumatic brain injury or high spinal cord injuries, usually above T6. And you get a complete or partial autonomic disruption, which is going to really lower your peripheral vascular resistance. And instead of getting hypotensive and bradycardic, hypotensive and tachycardic, which is what we see in septic shock and cardiogenic shock, you actually get hypotensive and bradycardic. You're looking at a higher mean arterial pressure as a goal for this, similar to the way you would be looking for one in a stroke, because you are trying to perfuse the spinal cord and preserve neurologic outcome. Contrary to a lot of the shocks that we treat, you want to minimize fluids in these circumstances because you can get spinal cord edema. And obviously, with any injury that transects a spinal cord or causes traumatic brain injury, you want to look for other sites of bleeding that are contributing to the hypotension. Moving on to the sepsis and septic shock, which is what we see most commonly in the ICU. Just a couple of stats that I think are going to be important as we look at a couple of the most recent literature and innovations. 15 to 19 million deaths per year globally. and it's got a 60% mortality in developing countries. Remember, the criteria for sepsis isn't that hard to get to. It's a suspected infection. It's hypotension that responds to fluid or doesn't respond to fluid, in which case you have shock. It's fever, tachycardia, a lot of septic patients. And for a 60% mortality in developing countries, it's a big problem. It's got septic shock has a 40 to 50% mortality in the United States. And we do a little bit better with run-of-the-mill sepsis, and we're less than 20% in that regard. The best way I could tie in everything for a definition of sepsis would be as an infection-induced generalized intravascular inflammation that results in disruption of the typical cardiovascular adaptive responses. And the reason I put it this way is because to drive home the point that it's not the actual organism, it's not the bacteria, fungus, or virus, it's the inflammatory response that the body takes on in response to these things that actually kills people. And hundreds of millions and potentially billions have been spent over the last 3 decades with really not too much mortality improvement. So this is a relatively classic slide, and I have to describe it because I can't point. But if you look in the lower left, you see that your innate immune cells are exposed to pathogens, bacteria, fungus, and from there you get leukocyte activation. There's a huge cytokine liberation, some people more than others, and this cascade goes on to cause tissue edema with capillary leak. You get thrombosis and platelet activation intravascularly, resulting in hypotension, vasodilation, decreased oxygen delivery, and this altered microvascular flow, which is the hallmark of sepsis progressing to severe sepsis and septic shock. You look at the yellow box in the middle, to the left of it, where you see protein C, activated protein C, fibrinolysis. This is where people really concentrated in the early 2000s. I don't know if anybody remembers Zygris or activated protein C. It was a medication that was with a lot of anticoagulant properties that was supposed to be a cure for sepsis. Unfortunately, turned out not to be. The surviving sepsis guidelines give us an algorithm for how to approach these patients, at least from the beginning. And this starts in the emergency room we have a code sepsis at Vassar. I think a lot of ERs do. And these patients get an initial 30 cc's per kilogram for initial volume expansion. And a lot of them respond to that, and that's the end. They get antibiotics, they get admitted to the floor, and hopefully they do well. Source control is obviously of the utmost importance, and this could be surgical. If it's a urinary tract infection, this could be just antibiotics. Early antibiotics are key, and we follow this very closely with quality metrics from our emergency room up. And then if they're not responding to those things, then they get vasopressors, inotropes, all guided by mean arterial blood pressure and lactic acid, which are two kind of very crude measurements. So what about arterial elastance, left ventricular and systolic elastance, ventricular atrial coupling, and LV ejection efficiency? This sounds like a lot of things, and it is a lot of things. Imagine giving an ICU nurse these parameters to document every 10 minutes. I could tell you that wouldn't go very well. But these are actually indices that we can get non-invasively. We can get them through a central line and an arterial line by looking at the waveform of the arterial line, something called the flow track. There's different variations of the flow track, and we use that in some of the trauma patients and some of the cardiac patients, and it's catching on a little bit, but it's a lot of work. And so there was a group at the University of Pittsburgh that took this on, and I think that these guys probably just wanted to get this paper published in a physiology journal because it was just going to prove what we kind of already knew, that if hypotensive patients who we suspect are septic get volume expanded, inotropes, vasopressor support, their hemodynamics get better. And they wanted, I think, to show that in a very fancy way, which they did. And here's all the indices lined up, and all of them got better. A few of them didn't respond to some of the medications, but they found a couple of interesting things. And the lower left graph will tell us that the patients that volume expanded appropriately, and their cardiac index improved. The ones that stayed on norepinephrine actually had an uncoupling effect with left ventricular ejection fraction and afterload that actually hurt their cardiac response to these medications over the next couple hours. And this is something new, potentially novel, that's going to make us think twice about individualization of vasopressors or fluid challenges, because everybody's getting the same thing right now. It's usually normal saline, 30 cc's per kilogram, and then the next thing that we give is norepinephrine, period. That's what the surviving sepsis guidelines say, and that really hasn't been challenged. So this is a paper from just actually a few months ago that is starting to challenge that, which is might have been a little bit of an accident, but that's sometimes how we find out a lot of important things in medicine. So could the surviving sepsis guidelines be revised? I think they definitely are going to be. The most recent revision was 2017, and I think that we're going to see more individualized fluid challenges, dynamic hemodynamic monitoring in response to the fluid challenge, which this study was based on, and then individualized use and timing of norepinephrine. I think we're going to see is going to be very important. Staying within the sepsis scope, there is a group of doctors in Virginia at a hospital about the same size as Vassar who had 3 very sick patients with septic shock that we'd call refractory septic shock, or too far gone, multiple pressors, and they decided to try something that theoretically should work with steroids, vitamin C, and thiamine, because theoretically that hits all different areas of that the pathways of the slide that I showed, and the patient should get better. It was a long shot, but all 3 patients survived. And everybody, of course, said, well, that's just, that's biased, and that's just 3 patients. It really doesn't matter. So they took it upon themselves to do an observational trial with 94 patients, which is a decent number. It's an observational trial, so that's a limitation. It was limited to severe sepsis and septic shock, which is good. There was no industry involvement, and that's a big deal nowadays. They used IV hydrocortisone, vitamin C, and thiamine, which is literally pennies on a dollar, and that's for globally that's the biggest benefit of this was cost, literally very little cost. And so what they saw was very impressive. They saw that the SOFA score, which is a severity of illness score, was much lower in the treatment group than the control group of the people that lived and the people that died. They showed that the procalcitonin level, which is a marker of bacterial antigen or infection-causing sepsis, was significantly lower on the treatment group than the control group. They showed that vasopressor requirements were much lower even in the people that survived. And last but not least, they showed almost a 40% mortality improvement, which is unheard of in any sepsis study. So this study has a lot of limitations. There's a much bigger one coming out. At Vassar, we implemented this metabolic resuscitation protocol, and as of earlier this year, anybody with severe sepsis gets it. It's very easy, it's very cheap, and it's potentially groundbreaking. Cardiogenic shock, I'm going to go relatively quickly here and just give the basics, because we're going to get a great talk right after me from one of the heart center cardiologists. But a cardiogenic shock is defined as persistent hypotension in the setting of decreased cardiac output, inadequate or increased filling pressures or pulmonary capillary wedge pressure. MI and LV failure are the most common causes, but there's also mechanical causes with ventricular septal or free wall rupture and acute mitral regurgitation. Very high mortality. This is just a pie chart showing that it's predominantly LV failure, but mitral regurgitation is a distant second, and then some of the other more rare causes. Treatment is reperfusion, if at all possible, with stenting or cardiac surgery. The ventilatory and hemodynamic support involved in this is going to be very important. Fluid management, usually guided by a pulmonary artery catheter with vasopressors and inotropes, also very important, and most of these patients need dialysis of some sort. If the vasopressor requirement continues to increase with worsening mixed venous saturation and worsening lactic acidemia, then mechanical circulatory support is considered. And that's what's really revolutionizing the way that we treat these patients, and we're doing it at Vassar with some really cool results, as you'll see in Shallon's talk. Mechanical circulatory support used to be limited, 10 years ago. It was an intra-aortic balloon pump, and it was a big deal to have somebody come out of the cath lab with a balloon pump, and it was one-to-one nursing, and everybody wanted to see it. And we still see them, but not nearly as much. Now we have these fancy things called Impella, and there's two different sizes, and they're very expensive, but they work, and the technology is incredible. There's an RP Impella, which is a right-sided Impella that takes care of right heart failure. There's VA ECMO, which is the ultimate mechanical circulatory support. There's tandem heart, which is kind of a takeoff of ECMO that crosses the septum. And then, of course, there's left ventricular assist devices, or LVADs, which really an Impella is, but these I'm talking about more permanent devices that patients have when they're waiting transplant. And we are not yet an LVAD center, but we're becoming one, I think, right? Yeah. This is an Impella. It looks like a big, thick catheter, which it is. But it's a very fancy and expensive big, thick catheter. And it's got to be positioned perfectly across the aortic valve, because you've got, at that little hook there, you've got the inflow. And then there's actually a little pump in there that pumps blood into the aorta. You can do that between 2.5 and 5 liters per minute, giving you a lot of support. And X-rays show, you see the arrows show that this one is in pretty good place. Placement is very important, because if it's not in the right place, you can get a lot of hemolysis and a lot of mechanical complications. VA ECMO, again, this is the ultimate mechanical circulatory support. You're draining the right-sided circulation, or venous circulation. It's going into a pump that can pump 5 liters per minute, which is more than adequate cardiac output for any of us. It's then going to an oxygenator, which oxygenates the blood, takes the carbon dioxide out, gets warmed up, and then placed back into the arterial circulation. We can do this peripherally now, and sometimes centrally, but this is cardiopulmonary bypass. I'm going to end with obstructive shock, and the two main types of obstructive shock are pulmonary vascular, which are pulmonary embolism, and then mechanical complications are something like pericardial tamponade with big pericardial effusions. And I'm going to start with a very brief case just to illustrate a couple of points. 57-year-old man with newly diagnosed lung cancer presents with shortness of breath, pleuritic chest pain, and pre-syncope. His blood pressure is normal. He's tachycardic, tachypnic, and hypoxic, and his lungs are clear on exam. Point of care echo, which everybody's seen a lot of already this morning, shows that chamber that you're looking at is a big RV, and it's scalloped at the bottom of it, which is called McConnell sign, very specific for hemodynamically significant pulmonary embolism. And you can do that all by ultrasound. You always get a CT angiogram anyway, and you see here saddle clot in the middle of left and right main pulmonary arteries. A little bit further down, we get more evidence from a CT angiogram, and you see a big right heart. The right heart is the closest to the sternum. The RV to LV ratio should be about 0.9, and as you can see, this right heart is 2 or 3 times the size of the left heart right now. So this is massive right heart strain in a patient with a normal blood pressure, though, so they're not in shock. So it gets complicated. This is the chart we use for our pulmonary embolism response team to risk stratify the patients, and this patient is not in shock, but is an intermediate high risk probability of dying during that hospitalization with a mortality of around 20%, which is high. That's 1 out of every 5 patients. So our pulmonary embolism response team employs different ways of treating these high-risk clots. And most recently, and I talked about this last year at this conference, for the last 3 years, we've been using a device called ECOS. And ECOS is a catheter that goes directly into the clot. Or on the left side of your slide, it shows that the catheter is on top of the clot, dripping TPA. That's what we used to do, and the interventional radiologist would help us with this, and it would work sometimes, but you see that a lot of the TPA can escape through the other branches. B is an ECOS catheter, and it's a catheter that goes directly into the clot, and it actually distributes the TPA directly into the clot for a much more localized approach. and it works much better. And the Seattle 2 trial in 2014 was the big paper that came out with 150 patients, most of which were submassive PEs, dripping TPA directly into the clot burden at a rate of 1 milligram per hour for 24 hours, for a total of 24 milligrams of TPA for the duration. Very good results. One death attributed to PE, which if they had 31 massives, that's a really big deal. No deaths in the massive PE group within 30 days follow-up. That's also kind of unheard of. And then the biggest one is no intracranial hemorrhage. And intracranial hemorrhage is one of the most feared complications of TPA. So people really like to see that too. And hence, ECOS was kind of launched at this point for the treatment of high-risk PE. It's very safe, and that's been proven. It improves RV function in the first 24 hours compared to standard therapy. That's going to help a lot of people. There's less vascular complications of DVT and PE beyond the 30-day window, which is going to help a lot of people as well. But as of yet, there's no mortality benefit that has been proven, and I think that's going to change in the coming years. This can be used for massive PE or salvage therapy in submassive PE that's not getting better. At Vassar, we see 5 to 6 PEs per week. 5% of these are supposed to be massive. So if you do the math, that's about 1 massive PE every month, which is about right. And, Dr. Lou said that they see, aortic disease and dissection like candy at Yale. We see a fair amount, but we definitely see PEs very regularly. That's probably our candy, if that's a comparison. There's no shortage of these cases. This is an illustration of a left pulmonary artery with big clot and filling defect in the upper square with poor perfusion. 1 hour after ECOS with the initial small TPA bolus, you see much better perfusion. Still some residual clot, but that's gonna significantly help the person. What's new in PE? Well, this is last year's trial called Optilice, and this was an important one. It is industry sponsored. Most of these are going to be when there's a device, but they did a pretty good job with it. They took 100. It's a little bit over 100 patients at 17 centers, and they divided these patients into 4 cohorts. The first cohort got a low dose TPA. For a total of 8 milligrams over 2 hours. The next cohort got that 4 to 8 milligrams over 4 hours. Third cohort got a little bit more, 12 milligrams of TPA over 6 hours. And then the fourth cohort, as you can see, that only had 18 patients. There's a reason for that. Got the 24 milligrams of TPA, which was the same as the original trial, but only got it over 6 hours. So in a quarter of the time, they got the same dose of TPA. They did have 1 intracranial hemorrhage in that fourth cohort group, so they stopped that cohort. And after 18 patients, after that 1 complication, but that was the only. It was not the only bleeding complication, but it was the only death. They measured very closely the RV to LV ratio with echocardiogram, and they showed no difference in RV improvement at 48 hours in all 4 dose groups, which is very big and important information for us to have. There's a 24% reduction in RV size and strain within 2 hours, which was the smallest dose, fastest time. And as mentioned, they had 1 intracranial hemorrhage. This is important because, number one, they're taking an ICU bed for 24 hours for the TPA administration. Excuse me. And then they have to be watched for usually for 24 hours after that, which is our protocol. So it's 2 days in the ICU. If you could do this in 2 hours and get the same RV improvement, then you're improving, not only are you improving the patient's RV, similarly to the 24-hour dose, but you're also improving ICU throughput and minimizing their exposure to the intensive care unit. So this is also potentially groundbreaking for how we treat this high-risk PE population. For the massive PEs, there's always VA ECMO, and this is the ultimate support for PE. So for PEs that cannot go to the operating room for embolectomy, that are in refractory shock with escalating doses of vasopressors and inotropes, which we see, and it's usually very hopeless, very high mortality. VA ECMO now supports them They're all hypoxic, so they get oxygenated with cardiopulmonary bypass. They're all in RV failure and usually LV failure, so their heart is supported with the pump. This works very well and is actually protocolized at some of the bigger centers, and we hope to follow that very soon as well.